We're going to talk today about African American and patients that have scleroderma. We're going to talk about the frequency and the outcomes and how they're different in African Americans. Some very specific clinical features and major problems that seem to be more severe in African Americans and how it's important that you know how to deal with these so you can be very proactive in dealing with your health. And then we're going to discuss some possible reasons why these differences occur. Whoops. Okay, so this is a graph. I tried to not do too much of the graphic data, but this is the incidence of how often scleroderma occurs in African Americans. This is women, and this is men, and this is Caucasian women and men, and this is the age range. And I think you can see that both of these lines are higher in African Americans, so that it occurs more frequently, and it occurs at a younger age, particularly in women, than it does in Caucasians. And the only reason why it's not more prevalent overall is just because the overall number of African Americans. But within the African American race, the incidence of scleroderma is actually higher. And the outcome, this is another graph that... The top two are women and men, Black African Americans, and these are women and men Caucasian. Sure. And these are the mortality rates. This is a fancy sort of age adjusted, and it doesn't really matter the actual numbers, but the point is that African American female and male both have more severe outcomes than Caucasians. So the disease is more severe in African Americans. And the presentation of scleroderma is different in African Americans. So the most common cause of onset of scleroderma is Raynaud's. And yet, it's harder to recognize in African Americans. The paleness is not as obvious in African Americans. And I've had many patients that say, oh yeah, my fingers get a little funny color, but they don't think of it as turning white or blue. And also, it's interestingly not as commonly the very first symptom. Actually, many of my patients have pigment changes as the very first symptom that they notice. The real increased dark pigmenting on the skin, or possibly the white pigment, what we call hypopigmentation. And that makes for a little bit presentation and often a little bit more subtle onset, so it makes it a little bit harder to diagnose. The skin thickening, the frequency, the severity is very similar to that in Caucasians, except that it tends to be, if you compare African Americans and Caucasians who both have the diffuse form of the disease, meaning that the skin thickening can be overall over the body, it's generally not quite as severe as the Caucasians. But it's certainly, there are more patients that have diffuse disease than Caucasians. So that tends to contribute to why people have more severe disease. And these are just some of the pictures that show some of the pigment changes, the very increased hyperpigmentation, and the white pigmentation that happens so commonly. This is similar on the skin. We call this salt and pepper changes. Happens on the fingers and the hands. It really can happen anywhere. This was a study that I did by one of the young investigators who's now here, Dr. Gordon. And when she was a resident with me, we did a survey of our African American and Caucasian patients just to see how their body image affected them. And as it turned out that Caucasians were not as affected by their body image as much as African Americans. This is the severe or moderate severe distress as opposed to mild distress. So more African Americans had distress. And when we talked to them and asked them questions about what caused them the distress, there really were significant differences. As I mentioned, this body pigment, the dark and the white body pigment, was much more distressful to the African Americans, whereas in the Caucasians, it's the wrinkles around the mouth, the wrinkles above the lips and around the mouth that was much more distressful to them. digital ulcers, the soreness in the fingers, suggesting that maybe the African Americans had more severe digital ulcers, was also more distressful than the Caucasians. So the discoloration, part of that is just because the melanin and hyperpigmentation in general is more common in African Americans. It's an early manifestation of the disease. Also, when you have inflammation, anytime anybody has inflammation from anything and you scratch it, you can get what we call a post-inflammatory reaction, and that is associated with increased pigment. It irritates the skin and the cells underneath the skin to cause increase of the melanin. And so that's a contributing part of it. And then because the way of scleroderma works, it causes decreased pigments. So all the abnormalities in the collagen and everything, it affects the melanocytes and how much they make pigment or not make pigment. And so that leads to the salt and pepper changes, which the fancy medical term is poikiloderma. I like to say that. So the natural history of, since this is more active early in the disease, as the disease progresses, sometimes the darker pigment lightens and sometimes the whitened pigment darkers. So it tends to even out over time, but it doesn't completely go away in all patients. And so this is I think what you were talking about as far as the little hair follicles, but it really is tended to be much more spotty than in that vitiligo type of picture. So there are a bunch of treatments, and that's always a very common question that African Americans have, and I've worked with my dermatologist to share with you some of the things that we do. Because being exposed to the sun causes increased pigment and sunburn, but also pigment, it's really important to use good sun protection. And that includes clothing, hats, sunglasses, but also specific sunscreens with the wide spectrum UVA and UVB protection, using something that has an SPF greater than 30. So this is really important because that increased sun exposure will make your pigment darker. So I have a lot of Caucasian patients that go out in the sun and never lose their tan, and that's a really positive thing for them sometimes, but I know that that's not a big positive thing for you. So there's another compound, vitamin A derivatives called retinoids. They really is available by prescription. There's a topical one. There's one that's called retinol formulation that is an over-the-counter one. The dermatologists use this. I've not personally used this because my patients have so many things to cope with that it's just hard to keep adding more and more medications. But this supposedly changes the skin pigmentation by improving the cell turnover so it doesn't turn over things quite so rapidly. But it does cause dryness and irritation. And as you all know, the skin in scleroderma is often very dry to begin with. And so I've been, again, a little cautious in using it. There are hydroquinones, which are bleaching creams. And this turns off one of the enzymes that makes pigment tyrosine, tyrosinase. And it's one of the main things that's part of sun protection. It is available in an over-the-counter preparation as well as by prescription, but overuse can cause a paradoxical darkening of the skin. And so again, even though the dermatologists use these different things, I've tend to encourage patients to use more of the way of makeup and covering up of things rather than trying to actually change things. I found an interesting article a couple of years ago that uses natural treatments, and I've not come across anybody that's really found them successful, but these are all things that actually were studied by this group of people that looked mostly in animal models types of things, so that there are potential different things and again, these are all, quote, natural treatments that have some effect on the pigmentation in skin in general, not specifically for scleroderma. So this is from a study of mine from the University of Pittsburgh, and this took us 30 years to get 200 patients with, that were African American, and we compared them with Caucasians, as you can see, a much larger number. But the important thing here in this group, the age of onset in African American was definitely younger than those that were Caucasians, and the frequency of having the diffuse form of the disease, the more extensive skin involvement, was significantly different. And so that, again, makes it some of the ways that it's different in African Americans. And then we divided them, all the different organ involvements. We have a definition of what we call severe, not just the presence of a specific organ involvement, but whether it was a more severe form of it. And these are the different ones that we looked at. So as far as the severity of the skin, there didn't really seem to be much difference. But muscle involvement, 27% of African Americans and only 12% had severe muscle involvement, more weakness, more difficulty raising the arms, getting out of the chair. They also had more severe gastrointestinal problems, and importantly, more severe pulmonary fibrosis. And so the other organs, the heart, the pulmonary arterial hypertension, and the kidney, really didn't seem to be statistically different than Caucasians. They occurred with about the equal frequency. But these three organs were definitely more severe in African Americans. And so I'm going to go through some of these features just a little bit in more depth to point out what things you can do about them. So the muscle involvement. There are two kinds of muscle involvement in scleroderma. One is an inflammatory one, meaning that there's inflammation and it causes abnormal blood tests. There's an enzyme called a CPK, which is a sign of inflammation in the muscles, and it's in the blood. And this is usually associated with really pretty impressive weakness, particularly in the upper arms and the upper legs. And so that means that people have difficulty getting out of chair, raising their arms, holding their arms up. And usually when we see this, it requires pretty potent medicine, sometimes even high doses of steroids. We try to avoid really high doses, but often requires steroids and other medicines like methotrexate or Imuran or Cellcept. There's another kind of muscle involvement, which is a fibrotic process, which means scar tissue. And so the same kind of thickening that you get in your skin, you can get in your muscles. And this does seem to be a little bit more common in African Americans. It may have a little bit of increase in the CPK, but it is often associated with not really severe weakness, but just enough mild weakness that to me, it's one of the main reasons why I think African Americans have more problems with their shoulders. Many African Americans have what we call contractures. They can't raise their arms up all the way. And that is a big problem. And people don't even notice that they have gotten that way because it happens sort of gradually, and you just don't, what? You just sort of live with it. But I think it's really important, and I educate my colleagues so that they look for that in African Americans, particularly so we can be more aggressive at doing physical therapy, at doing exercises, at strengthening the arms and the shoulders so that we can maintain that motion. Usually this is just treated, as I said, with exercise and with maybe a little bit of prednisone, but usually not lots of medications as far as in comparison to the inflammatory. And then there are some patients that have just increases in the muscle enzyme. They just have a sign of it. If there isn't any weakness at all, then that part doesn't need to be treated. So the treatment, as I said, it's range of motion, meaning moving your arms all the way through the different ranges, and strengthening exercises, particularly of the shoulders. The anti-inflammatory, sometimes there's a pain associated with this, and so we give patients analgesic pain medicines, Tylenol, even occasionally we need to use some codeine with it. Occasionally we use the steroids that I talked to it. I think it's also very important to have a regular exercise program as far as walking, bicycling, swimming, something to really keep your whole whole body in tune. That's going to be important as far as our cardio exercise program as well, because African Americans have problems with their lungs. We really have to keep your cardiopulmonary status as optimal as we can. And so that's why exercise really is important for our patients. So the GI symptoms. So the GI symptoms, and probably you've heard our colleagues talk about a lot of the GI symptoms, and the area that seems to be more severe in African Americans tend to affect the small intestines. And the symptoms that are associated with the small intestines are nausea, bloating, full feeling, distension. Your belly looks like it's 6 or 7 months pregnant. It just gets very, very bloated. Sometimes vomiting, oftentimes diarrhea. Sometimes it's associated with very severe weight loss. And then sometimes it also can be with constipation, because it really is associated with a lot of symptoms, and it can be associated with a lot of weight loss. And this is a really big challenge, because it's one of the few manifestations of scleroderma that we don't have a lot of good treatments for. Let me finish Matt's questions. So these are just some pictures here of the involvement. This is a small intestine. Normally it's only about a quarter of this size, and this is just a huge amount, and you can't really see it, but that when you get this big distension, it's basically the intestines just all dilated up, so they're very enlarged. And it's really hard because we have treatments for the reflux and the heartburn, but we don't have a lot of motility drugs. So the problem with this is that the intestines doesn't move well. The motion, what we call peristalsis, doesn't move things through the intestines. And so it just sort of sits there and gets dilated. They can get a lot of bacteria, what we call bacterial overgrowth. And that sometimes is treated with antibiotics. But the biggest problem is just that we don't have anything to give that intestinal the oomph to have it move everything through. And so you all have to work very hard at maintaining your nutrition, finding the right combination of protein and fiber, and whether it's gluten-free or whatever it is, you need to work hard to maintaining your weight. Probiotics seems to have sometimes been helpful for patients as far as the bloating and the distension. And as I said, antibiotics for the bacterial overgrowth is usually what we call an intermittent type of program. So you take an antibiotic for a while, and then you come off of it, and then you go back on a different antibiotic, and you rotate them. And it's really kind of just a trial and error to see how you respond to it. Constipation, the usual types of treatments. We use a lot of Miralax because it isn't quite as harsh. It's what we call an osmotic. It means it just, with liquid, it helps moves things through the intestines rather than a real harsh laxative. So the lung is really the biggest problem in scleroderma, and that really is the thing that's been limiting the survival in much of our patients. As you can see, both pulmonary fibrosis and pulmonary hypertension, when you look at the reasons why scleroderma patients die, the lung accounts for almost 50%. I might add that more than half of patients with scleroderma who die, they die of non-scleroderma related things. So not everybody dies of the disease. So the risk factors for the development of the severe pulmonary fibrosis, it usually happens early in the disease. It happens more commonly in diffuse scleroderma. And it happens more commonly with these two autoantibodies, SCL70 and a nucleolar antibody. And they happen to be the two most common antibodies that occur in African Americans. And I really think, and as we'll show, that's one of the main reasons why African Americans have severe lung involvement. And it's really important because we have lots of different medicines that we're studying and we're using to treat it, but it really has to be identified early and treated early. Once the damage has been done, we don't have any medications to break down that scar tissue. We only have medicines to try to prevent it from happening. And so that's why we do these pulmonary function tests in everybody the minute they get diagnosed, and watch those pulmonary function and make sure that they don't change. So these are just a couple of the parameters that we use. If the forced vital capacity is present less than 75% predicted, 80% is normal. So if it's already abnormal in the first couple years of disease, 18 months, that's a bad risk factor. Or if you are having your PFTs done yearly and you see that that FVC is decreasing, then if it decreases by more than 10%, that's a bad risk factor. Patients have shortness of breath with exercise usually first before they get shortness of breath at rest. But I really don't want to wait until people have a lot of shortness of breath. I really want to get people evaluated and diagnosed before they've developed the shortness of breath. Cough is something that happens, but oftentimes patients don't have any symptoms. And sometimes I struggle to convince my patients that they need to be treated, because it's really only things that I find on these breathing tests or on their CT scans. And yet I know, because there are those changes, that they are at risk for having more severe disease if we don't treat them. So even if you don't have any symptoms, we still have to be really quite aggressive. Most of this is just another of my little graphs here, but this represents how much loss of your pulmonary function happens over time. And you don't need to worry about the numbers, but I think you can see that these bars are much greater in the first 5 years of the disease than later on. So even though you continue to lose a little bit of function later on, most of it happens in the first 5 years, and that's when we want to try to treat people aggressively. These symptoms of lung disease are so nonspecific, and they can come from almost everything. They don't have to be just from lung. And so again, I don't want you to wait until you already have bad symptoms to have your doctors evaluate you for lung disease. So the shortness of breath that we were talking about, as I said, at rest, it's not, so the shortness of breath in scleroderma lung disease is different than asthma. Asthma comes on, you get very short of breath, you have wheezing, and it doesn't have really any relationship to exercise. This is really much more commonly associated initially with exercise. But actually, a lot of my patients don't even recognize that they have shortness of breath until I start badgering them. Can you really climb 3 flights of stairs? Weren't you able to climb 3 flights of stairs 3 years ago? But now you can't. And so you may not even recognize that you're short of breath. It may just be fatigue. You may just feel tired. You may just get used to it, and you don't go to the grocery store 3 times a week. You only go once a week. Or you don't go up and down the stairs to your room once a day now, and you don't even recognize that. And you really need to know about these kinds of things so you can tell your doctor, because your doctor's got a busy schedule, and he only has a short period of time to ask you all the questions about all your disease. So you think about the kinds of changes that you have with your lungs and your breathing and all these other things that happen, so you can tell your doctor. You don't have to say, oh, I can't breathe anymore, but make him aware that you're not doing as many activities as you used to do, or that you're much more fatigued than you used to do. Make him listen to you. So the clinical course in African Americans, as we mentioned, it occurs in younger people. More severe diffuse scleroderma, more frequent severe small bowel, pulmonary fibrosis, and actually pulmonary arterial hypertension that you heard about yesterday from Dr. Domsick also occurs, and it's interesting, it occurs more commonly in younger African American patients that have diffuse scleroderma. So even though the frequency overall is different, the population is different. So in Caucasians, it's the patients that have the long-standing limited cutaneous disease for a very long time before they get pulmonary hypertension. But in African Americans, it tends to be a much more younger population with shorter disease duration, and also in diffuse scleroderma. So it can be often very challenging to make that diagnosis. So why is this different? I mean, lots of things are different in African Americans, and some people will say it's socioeconomic status, access to care, not going to see a doctor, quality of care. I'm sure that may contribute in some patients. That's not my experience. In Washington, D.C., my African American population is working, have insurance, not an indigent population at all, and they have very similar scleroderma that I'm talking about. The other issue, which actually one of the patients brought up to me about 5 years ago, is general health attitudes. And I didn't even really realize this, but African Americans are a little more skeptical about health care and participating in clinical trials and taking medications and using more homeopathic things. And sometimes it is. And then since this lovely lady brought this to my attention, when I think it was the very first time I gave this lecture, I really have noticed, and my patients, I really have to really make sure they understand why I want them to take medications. And so make sure you talk with your doctor and have your doctor help you understand why it is that they want you to take the medications. The cultural differences goes along with that. But I really think that there are some major disease differences between African Americans and Caucasians, and these relate to the autoantibodies that occur in African Americans, and that's sort of just the marker of it, but it really relates to the genetics. And I think that the genetics that occur in African Americans are different than the genetics in Caucasians, and perhaps that's why scleroderma is different. So these are all the autoantibodies that we have in scleroderma, and the ones that are most common in African Americans are these three: SCL70, anti-U3, and anti-U1. The numbers don't mean anything, but they really are very different. These are the frequency in African Americans, and as you can see, look at majority are in this group, whereas the Caucasians, the majority are in this group. And when you compare the types of problems that people have, this is the patients with just with topoisomerase. So even though there's a higher frequency of topoisomerase or this SCL70 in African Americans, when you look at the severity of their lung disease, which is more common in SCL70 patients, it is, even with the same antibody, African Americans have more severe lung disease than Caucasians, really quite significantly. Again, we point out the earlier age of onset in African Americans than Caucasian, even with the same autoantibody. So the same marker, the same type of disease, there's something else going on that makes the lung more severe. And in one of the other very common autoantibodies in African Americans, this U3, here's this finding of more severe GI disease. GI disease happens in all scleroderma, and this is really the first signal that we've had that for some reason, something is different in African Americans that makes this particularly small bowel problem different. So there are genetic causes for difference in many, many different diseases. Certainly different things like hypertension and diabetes tend to be more severe in African Americans as well. We talked about the autoantibodies, and there are differences in autoantibodies between the two races, and it's probably, and those antibodies are associated with specific genetic markers, and those are different. So there clearly is a difference from a genetic standpoint. So we're in a situation right now that a very exciting time. The National Institute of Health has just funded and just started a very exciting, what we call a GWAS, or a genome-wide study, trying to understand the genetics in African Americans. We've done this in Caucasians, and there are lots of gene information coming out about possible pathways. And this kind of study is really mostly looking at pathogenesis and trying to find out why people have abnormalities in their genes that might allow them to have scleroderma. So this is really an exciting opportunity. There are sites all over the country that, and all it requires is a blood test. And we're really quite excited that this is, one, being funded by the NIH, but two, hopefully will allow us to get a better understanding of why this disease is so different in African Americans. There are other differences. We mentioned that African Americans have earlier and more severe disease, so there may be some enzyme differences that are different. There's a specific factor that plays a major role, TGF-beta, and that seems to be more common in African Americans than Caucasians. Maybe that's why the disease is more severe. Dr. Silver's been working on lung disease for a long time, and when he looks at the fluids using the bronchoscopy and he takes out the fluids from the lungs, he found out that there were factors that were abnormal even in healthy African Americans, so that there was this different enzyme that in totally normal African Americans was decreased, so they didn't make as much of this enzyme. And that enzyme, you had to have this enzyme to prevent the fibrosis. So one of his theories is that because just in general African Americans don't have this specific enzyme, that's why they can't prevent the development of fibrosis when they have scleroderma. So we're trying to figure out ways why it may be that African Americans have more severe disease. So in summary, scleroderma is more common, occurs earlier, and is more severe than in Caucasians. Muscle, small bowel, pulmonary fibrosis, pulmonary hypertension, all are severe problems and contribute to the differences. Although health disparities and cultural and all those things may play a role in some of the differences, I really think that it is probably a major differences because of the type of disease that African Americans have, and that probably is because of the genetics, which is probably what we're going to find is the major differences. So I think it is really important that you particularly understand your disease and work very closely with your doctors to make sure that your treatment is as optimal as you can. Thank you.
You know, there's a CPK number you get, which is the normal, and that will be a high number.
So normal as far as pulmonary function tests?
Not the pulmonary function, the CPK number in the muscle.
CPK.
The CPK.
Okay.
Number.
So normal is different in the laboratory. So it depends on what your laboratory. It's a blood test. It's a chemistry test. Most of the time normal is below 200, but some labs it's different. And so you'd have to read on what the chemistry test says. So
yeah, okay. Mine's came up as 203.
Yeah. So again, I don't know what the lab is, because sometimes
by
it's
the lab number, it has 0 to 120.
Okay, so yours would be, if it was up there, it would be a little bit elevated, right? So not knowing individual things, that could mean that there's a little bit of inflammation, or it could mean that it's just an abnormal test, and it would depend on your doctor evaluating you as to whether you had weakness or not. So it's not just one thing, it's not just the blood test, it's a combination of the blood test, whether you have weakness, and then we actually have other tests that we do to find out whether there's inflammation or scarring.
Oh, okay, I got none of those, so I can't ask you a question. But I do have weakness, and she explained it was from that CPK number, supposedly.
Hi, my question is about your slide for risk factors for severe fibrosis. You mentioned that the FVC levels were less than 75% in the disease with African Americans, but you didn't mention anything about the DLCO, so I was wondering how much that decreases over time with African Americans, and is it more prevalent in African Americans decreasing than with Caucasians?
So I was talking mostly because fibrosis, the test that we measure to measure scar tissue, is primarily the FVC. The DLCO can be a measure of either vascular problems or scar tissue. And so that can be, it doesn't separate between fibrosis and pulmonary arterial hypertension. that can be low in both fibrosis and in pulmonary hypertension. And over time, that can decrease as well.
But you have no data as to whether or not African Americans decrease significantly more?
So I don't think that there's as much of a difference in African Americans, mostly because Caucasians that have the higher risk for pulmonary arterial hypertension, the limited scleroderma patients, the anti-centromere antibody, the classic patient that gets pulmonary hypertension, those patients get isolated decreases in their DLCO. So they have the decreased DLCO over a long period of time. So when you compare the two races, because they're different reasons why they have the low DLCO, there tends not to be as much of a difference.
Okay, thank you.
Thank you so much for doing this talk, and I'm so glad that I followed the leading and came. I just want to make one comment and a question. I'm 11 years diagnosed, and I believe that a big discrepancy has to do with the nature of our relationships between Black and Caucasian people, that typically, when it is not an extended relationship, there's generalizations to where I find that I'm not spoken to in a direct manner that appreciates my intellectual capacity. And as a result, what you said helped me understand why you want me to take this medication. It seems that because of some of the distrust issues and that typically the Caucasian person will kind of tell you what to do, but not really talk to you on an equal level of thinking that I'm responsible for helping you understand. And so that's what I found, that my doctors in the beginning did not share with me the critical factor of you must do this within the first 2 to 5 years, or you will not be able to do this intervention later. Right. And also the issue is when you're coming along, you're often not perceived to be on level, because you are not perceived to have the support system to hold that doctor accountable. I believe that is the nature of the discrepancy, is because of the early lack of intervention and the early not understanding the seriousness.
I'm sure that contributes a lot. And we're still very much struggling to educate rheumatologists about scleroderma in general. And so when you get a doctor that's insecure to begin with because they don't even understand as well about a scleroderma, then you add these cultural and racial things, it certainly can be a challenge.
And my question, you mentioned about, I don't know if I heard it right, but I thought I heard you saying that you're going to at some point come outside of being at risk. Because I wrote, are we ever no longer at risk? And, I'm just, because it was in the context of risk factors for severe fibrosis. Is it not a long-term, lifetime risk?
So the onset of the severe fibrosis usually happens, as I say, in the first 5 years. If you are 10 years into your disease and you don't have any fibrosis, the likelihood of you having severe fibrosis is very, very small. Now, if you have mild to moderate fibrosis, over time, you can get some additional fibrosis. But, we don't have medicines at this point that really can do that much for that small degree of change. And our medications are pretty toxic. And so that's why we've tended to focus on the early disease patients where we think we can make the biggest difference and have the less risk. Because if we expose everybody that has a little bit of activity, that little bit of change that we might be able to prevent from happening, and yet the drugs have a lot of risk. So that's why, again, we focused on the early
And could you also explain when people use that term shortness of breath, does it equal shallow breathing? Is that the same thought, or is it something else?
For you, that may be how you manifest shortness of breath.
So there's more than one manifestation
Yes,
of shallowness
absolutely.
of breath, shortness of breath.
Right.
Could you speak to that at all?
There are so many different presentations of shortness of breath because everybody perceives it differently. I mean, some people, as I said, I had one lady that absolutely denied, totally denied that she had any shortness of breath. No, I don't have anything. I happened to give her a drug. It was for pulmonary arterial hypertension, which made her much, much better. And she came back and she said, oh, I can go to church now. I haven't been able to go to church because I couldn't climb the 3 flights of stairs to get, or the stairs to get there. And yet she still denied she had shortness of breath. So she had just totally adapted her life. So shortness of breath is very, very, very subjective.
Hi, thank you. Thank you for speaking.
It's just for the camera.
Okay. I was diagnosed probably about 5 years ago, and I started off with the Raynaud's, and I kind of just blew it off, thinking it was like I had back surgery, maybe that was a botched thing. It wasn't until I got pregnant with my son that my body went haywire, and then they had to do emergency C-section. The next day I ended up in the ICU, and I was diagnosed with lupus first, and then mixed connective tissue disease. Like, we didn't really know what's wrong with you, and it took me losing actually 15% lung capacity for them to get the diagnosis correct. I have my good days and my bad days, and I feel fine, but my last test came back and said that my muscle enzymes had tripled, and I wanted to know how you felt about the drug. It starts with an R, it's
Rituximab.
Yeah, I'm not feeling great about it. I was on methotrexate for a while and didn't really do anything, and prednisone once in a while, and then I wanted to try Cellcept, but my rheumatologist now feels like I should do that. But my fear is I've read the not so great things about it, and I have a 6-year-old now, and I don't want to.
So there's several things in your comments. One, African Americans have because they are also more likely to get lupus, and scleroderma is often sort of hard to diagnose. It's not at all uncommon for African Americans with scleroderma actually to have the diagnosis of lupus to begin with. Whether there is overlap with some of the manifestations of lupus and scleroderma more commonly in African Americans, I'm not sure we know. U1RMP, which is the antibody that's associated with, quote, mixed connective tissue disease, is one of the very common antibodies in scleroderma in African Americans. And often those patients start out with lupus symptoms. That's how the mix comes from. They have some lupus symptoms, they have some muscle symptoms, they may even have some rheumatoid arthritis symptoms. That all commonly happens in the early disease. The Raynaud's is always there. And then oftentimes some of the scleroderma manifestations really don't happen until all the lupus-y things sort of quiet down. So it's a really challenging diagnosis for patients to understand as well as for doctors to understand. Getting back to the treatment, so just rituximab. Rituximab is a new drug, or relatively new drug. It is really becoming very commonly used in some of our other related diseases. It's definitely used in rheumatoid arthritis. It's used in myositis. It's used in vasculitis, all with really significant improvement, okay? Hasn't been used in general for scleroderma. There are some reports that suggest it may be helpful for lung and may be helpful for skin, but we really don't know. So I guess your doctor's coming from that, from the muscle standpoint, and since so many of our drugs that we use for muscle aren't very good for lung, this drug, since it isn't bad for lung, is often what people use. So some of the things she's worried about, and I'm sure there are always, all these drugs have risks of infections, but there's also a risk of this really bizarre, unusual neurologic brain disease that has been shown. I think most of the patients that it has occurred in have been in patients that have been multiple strong immunosuppressive agents. I think you have to really think about not treating and whether there are other drugs that might be better, but I can, share your concern, and I think we've tended to be a little more cavalier with this drug just because we know it does work in certain circumstances, and the complication is so rare that it's hard to put that into perspective. If you happen to be the one person in a million that gets it, though, there's nothing any of us could do. So it's really a risk-benefit type of ratio, which is really hard to evaluate for the whole patient. So, I encourage you to talk some more and see whether there are other medications that you would be more comfortable that would fit with you. But I don't think it's an absolute exclusion at all, because I think if it's used in the right way, it can be a very good drug.
Real quickly, just because the added stress doesn't help my scleroderma. And they took him out 26 and a half weeks. So with that, he is globally delayed cerebral palsy, epilepsy, autism, and has a couple different chromosome issues. So while I'm trying to figure out this drug, I'm also saying, okay, am I gonna have to find a home for him as well if something happens to me? It really is not fun. And the thing is, I feel fine. Other than my breathing, I feel fine. So when they keep doing all these tests on me and coming back and saying, fine for where I was at 5 years ago.
Well, if they're using it for lung, the data for lung is not as sound as it is for some of these other things. But I think they're just really concerned with you, and that, we all want to do what's best for our patients, but we don't have crystal balls, and we don't know.
You answer my question. I'm probably going to wait.
Thank you.
I just wanted to add to her question. I'm actually taking the rituximab therapy, and on Tuesday it will be my 6th time, and I've noticed that it helps a lot, that it helps me have more energy, and I could notice that once when I'm feeling weak, it's time for the rituximab. I call it my boost, and it's helped a lot. I have more energy.
So, medicines in scleroderma are challenging because the natural history of the disease are ups and downs. And that's why it's really important, and sort of why I emphasized last night, that we do these trials. So the first part of my career, probably long before you all had scleroderma, I believed in a drug called penicillamine. And I spent 10 years of my career trying to convince the world that this drug really worked. And it was mostly because we were treating people as they were getting worse. And maybe the drug was helpful, but there is a natural improvement in the disease. So that's why it's really important for us to all participate in trials and really find out whether these drugs work or not. In certain circumstances, we use these, quote, off-label, and the patient feels better. We don't really know whether it works. And so whether you can need to continue it all the time, it's very, very hard to tell. And that's, as you say, it's something you have to work out with your doctor.
Mm-hmm. And I just wanted to add that during the rituximab, I don't know what dosage I'm on, but during it, if they put it on a faster mode, I get really hot. And so if you get really hot, you could tell them to slow it down. It just makes me heat up a little bit. And then another downer about it is that the insurance, because
yes. That's a big downer. So it's a drug that's not approved, and so it's a real challenge to get it. So it's not a benign, it's not like taking a little pill. I mean, it's a big investment, both cost and with the patients. So it is in our, quote, armamentarium, but it's not a proven treatment yet.
Okay, I think I have a couple of questions if I can remember them. I kind of chemo brain. I was wondering, because of the higher, I guess, SCL antibody 70 of scleroderma in African Americans, if there is some type of treatment that works better for us than works for, I guess, the Caucasian majority, if there's any information on that.
We don't yet. We know that the only study really that we've done in the lung that has shown improvement was the Cytoxin study so far, and there wasn't any difference in the response in race to that. So whether, as we're going, meaning that both African Americans and Caucasians responded to it.
Okay, and also because the antibody is higher, what type of studies are being done regarding the hereditary aspect of
So
scleroderma?
the hereditary aspect, the genetics of scleroderma is not the same as hereditary. So all of scleroderma is actually a very low hereditary type of thing. So Dr. Mays has looked at family medicine and twin study. There's really a very low frequency of twins that have it. There's a low frequency of first degree relatives. Less than 10% of scleroderma patients will have a first degree relative. So that's a different type of gene. It's a hereditary. It's not like you have a disease that you're definitely going to pass on to your children or anything like that. So the genes and things that we're looking at are markers for why you get this antibody, and we're not exactly sure what that means. And so we're hoping that by doing these other gene studies, now that we know all the genes in the body, that they'll pinpoint something that will tell us why the disease happens. But it's probably not going to tell us much about hereditary, because we don't have, it's not like cystic fibrosis that we have a single gene that says you're going to get this disease. And so there really isn't much that we can do as far as letting people know that their relatives or their siblings or their children are at risk for getting it. They have an increased risk for sure, but there's not any kind of blood test that's helpful.
I was just wondering, because I'm third generation scleroderma patient, my father and my grandmother on my paternal side, and I want to have children one day. I actually missed the pregnancy and scleroderma to come here and get some more information because of that. And I just wanted to know, I guess, where researchers stood, about being able to conceive and knowing when it was you should get your child tested, or if you should at all.
So they wouldn't be able to tell in a infant whether they were at risk for dying. We just don't have those genes. Okay. I mean, even though you have relatives that have it, it's still not a single gene. There is a group of genes that make you at risk for getting these diseases, but it's not one gene.
All right, thank you.
I think we have time for one more question.
Okay, well, I know everybody's a little different, excuse me, and I have a little bit of a personal type of situation, and it's not based on drugs. I kind of like the more natural approach or whatever. So I have a 19-month-old son, and blessed that he's perfectly healthy so far, and I'm hopeful that he will continue to be. So I got off every medication for scleroderma that I was taking in April of 2012 when I found out I was pregnant with him. And the only thing I kept taking was omeprazole for I have acid reflux. So I haven't taken anything else since then, and I'm actually feeling way better. My pregnancy was perfect. I feel better than I did when I took other medications and drugs, and I felt sicker when I would be on these different drugs. So all I've been taking is like vitamin D3, vitamin C, prenatal vitamins, even if I'm not pregnant or whatever.
So it's important to realize this disease can stabilize and not be a never-ending progression. And sometimes people don't need a lot of medications. You still need to keep in close touch with your doctors to make sure that everything doesn't develop.
Right, but do you think that taking like more vitamins, maybe for African Americans, that maybe an extra boost?
I wish I knew.
Okay.
We don't know. We don't know.
All right, thank you.
All right, well, thank you all, and thank you for coming. Thank you.